All right, everyone, and thank you so much for joining us for our latest media briefing on important healthcare issues in the news. I'm Dr. Adam Kassam. I'm the president of the Ontario Medical Association, and we represent more than 43,000 physicians and medical students across the province. The pandemic has shown us the strengths of Ontario's healthcare system and the strength of the dedicated healthcare workers who have been on the front lines for the past 16 months. The pandemic has also exposed gaps in our healthcare system, and gaps that have grown wider because of COVID-19. As we emerge from the most challenging public health crisis of our times and start our pandemic recovery, we have a unique opportunity to rebuild our healthcare system, fix the cracks, and make it even better. Physicians are committed to working with government and our healthcare partners to do exactly this. We're also asking the public, the people who use the healthcare system, to help us think through what the future of healthcare could look like and what it should look like. The OMA is conducting an informal public survey to find out what Ontarians feel are their top healthcare priorities. The survey will remain open for the entire summer, but our interim results show that the public has 4 top priorities. The first is addressing wait times and backlogs. The second is access to physicians. The third is healthcare for seniors, including long-term care and home care. And the fourth is access to mental health and addiction services. The OMA will use the survey results along with input from doctors, healthcare stakeholders, and community leaders across Ontario to develop a plan for the future of healthcare in Ontario that will be released this fall. We encourage everyone to fill out the survey at betterhealthcare.ca and help shape the future of healthcare with us. Today, I'm really excited because we have 3 physician leaders here with us today to discuss how the pandemic has affected wait times, healthcare for seniors, and mental health care, and what we can ultimately expect to see in those areas as we emerge from the pandemic. With us today is Dr. Samir Sinha, who is the Director of Geriatrics at Sinai Health System and University Health Network in Toronto. He is also the Director of Health Policy Research at Ryerson University's National Institute on Aging. Dr. Sinha is a highly respected and regarded clinician and an international expert in the care of older adults, and he was recently appointed to the federal government's National Seniors Council and has been asked to lead the development of new national long-term care standards for Canada. We also have Dr. Renata Villela, who is a psychiatrist with an independent community practice in Thornhill, Ontario, where she focuses on long-term psychotherapy. In addition to her clinical work, she is the president and psychotherapy initiative lead for the Ontario Psychiatric Association and vice chair of the Ontario Medical Association section on psychiatry. We also have Dr. Simran Singh, who is a medical oncologist at the Odette Cancer Center at Sunnybrook Health Sciences Center and an associate professor at the University of Toronto. He is the provincial head and clinical lead for the person-centered care strategy at Cancer Care Ontario. And thank you all for being here. Dr. Sinha, perhaps we can start with you, and maybe you can start by outlining for us how the pandemic has impacted care for seniors.
Yeah, thank you very much, Dr. Kassam. The pandemic has obviously been quite devastating for older people, but in a number of different ways. And I think what the survey results are showing is that these are things that affect seniors in particular. Just at a global sense, we know that when you look at the numbers of people who died from COVID-19, 95% have actually been people who are 60 and older. And we know that across Canada right now, 58% of those people who've died have been those living in our long-term care and retirement homes. So we know that this is a pandemic that has disproportionately affected older adults for a number of reasons, but also you can imagine that this significantly impacts other aspects. If you're a person worried about getting COVID-19, you're more likely to shelter in place in your own home, be isolated, less likely to pursue medical procedures, medical appointments, and when you're reliant more on primary care or other aspects of the system, this means that there's a lot more deferred care happening and a lot more other challenges that one can have by not being able to access primary care. As many of us went virtual, that worked well certainly for some older patients, but a lot of other older patients like mine, most of my virtual care is done on the telephone, and me trying to guess what's going on without actually being able to see that person in place. from a social isolation, from a mental health perspective. My colleague will be able to speak to this a lot greater, but this just gives you a little bit of a flavor for some of the issues that have happened. But in terms of long-term care and what older people and what Ontarians are thinking in general right now, we know that over the last year, through our work at the National Institute on Aging, we've been surveying nationally, but also in Ontario. And what we've seen is that 78% of people in Ontario now say they rather receive their long-term care services at home, not in a long-term care home. 60% of Canadians in general, 70% of people, especially at the highest proportions in Ontario, have said they have reconsidered whether they'd ever want to live in a long-term care or retirement home for themselves or a loved one. And I think what Ontarians are telling us is they are now well aware about the challenges in our system, the gross underfunding, the lack of staffing, and how that actually leads to poor outcomes, including poor outcomes during a pandemic. So we have a real clear agenda ahead of us, especially when right now in Ontario, we have 9 times as many pediatricians as we do geriatricians. We have a shortage not only of physicians, but in particularly specialists, in geriatric care, whether it be doctors or nurses or others. And we certainly do need to think about, as we, quote unquote, build back better, how do we think about the needs of an aging population when soon enough, 1 in 4 Ontarians within 10 years will be an older person. I'll stop there, Adam.
Yeah, that's great, Dr. Sinha. And you touched on so many different points in such a small amount of time right there, and whether it was virtual care and how access, but also appropriateness becomes an issue, and becomes also a discussion about a good, high quality delivery of care, long-term care and home care, and how do we bolster community care in order to make sure that as we are aging and growing as a population, that we can do this in a significant and a meaningful way. And a lot of the results of the surveys that you just shared with us are enlightening, and I think allow us to really have a broader conversation of what the future of long-term care, of home care, really should and hopefully will look like. Dr. Villela, how has the pandemic impacted mental health care, and what can we expect to see in the coming months and years?
Thank you, Dr. Kassam. So it's really proven to be a marathon. We've seen a worsening mental health crisis as psychiatrists serving Ontarians were treating the most severe cases. And there have been stories from our fellow physicians and patients of astronomical levels of despair and worsening trauma as people were cut off from being able to tap into a variety of support networks. So issues like loneliness that were spoken to previously by my colleague, as well as unsafe home environments. And this could mean, for example, situations of domestic abuse or inadequate housing. So people have really been struggling to cope. And as a result, we've seen increases in substance use, complicated grief, suicidal ideation. The research has also been showing that psychiatric illness in and of itself is a risk factor for worse outcomes with COVID-19. So this is why telepsychiatry, be it in the form of the telephone or different video conferencing platforms, has been so important within our specialty for staying connected, because it's really helped break down some of the geographic and socioeconomic barriers that were preventing people from accessing care before. And in terms of that, then it's so key for minimizing hallway healthcare even beyond the pandemic. In fact, some of our patients have expressed being terrified that the resources that were now available during the pandemic could be taken away, because they still do add value as we move into the next stages. So this highlights that really any limits on these modalities and different treatments and therapies, especially long-term ones, can be quite devastating. So hopefully there's going to be an appreciation that it can take time for mental health issues to develop. And it's also going to take time to help people through the recovery phase. And these issues are then further amplified for racialized groups. We've already heard of certain clinics that are dedicated to specialized populations that are being constructed. In the news, there's been a focus on the struggles of the Indigenous, Asian, Muslim, and Jewish communities, just to name a few. So it's really important to be listening to these and other marginalized groups so that we can determine how best to be of service to meet their needs. The final point that I just wanted to make is with regards to, now that some of the restrictions are being lifted, how might people be approaching a reintegration into social activities that were modified or put on pause during the pandemic? And obviously, this is going to be impacting people across the lifespan. For example, on one end with children who had time away from school. And then, as Dr. Sinha was talking about in terms of long-term care facilities, there have been restrictions on visitors, for example. So it's important to be working with the public health guidance because there are some pieces that are likely here to stay. We think that tripod of the regular hand sanitizer use, masking in certain spaces, having to physical distances as well. There's also talk possibly of booster vaccinations. So those are going to have their time and place in helping us find that balance between minimizing the physical health risk while also optimizing mental health with this next transition. And it's been a time of high anxiety for a lot of people of what that will look like. So it's going to be really important for psychiatrists to help steer that and be part of the conversation. Thank you.
Yeah, thanks, Dr. Bilal. And I think it's safe to say that when we think about mental health crises and how mental health has been affected practically in every corner of this province by every segment of the population, it just really highlights the importance of timely access, but also expert access to care like psychiatry, like other primary care, GP psychotherapy, for example, as another modality, because really this is one of the aspects of perhaps what we are describing as a shadow pandemic of COVID-19, and we're seeing that in all age groups and in all corners. So thank you so much for that insight. Dr. Singh, we know that patients were concerned about wait times before the pandemic. It's certainly been an evergreen issue in the province. Can we expect to see them become even longer as more people are diagnosed with cancer and need treatment and surgery?
Yeah, I mean, I think we got to work together. That, as you mentioned, Dr. Kassam, that was a problem before, and we certainly got to work together with the government and with patients in a partnership. Listening to Dr. Sina and Dr. Viela, very similar themes in the cancer world of what has happened. The pandemic hit in March of 2020. We didn't know a lot about COVID at that time. And cancer isn't something we can really put a pause on. So there was a scramble to try to understand the virus, what the impact of the virus would be, but especially for us to understand what that might mean for our cancer patients. A lot of backup plans were being made for surgeries, for radiation, for systemic therapy or chemotherapies to try to ensure that we could continue to offer care during the pandemic. And you can imagine for a patient how scary it must be to have cancer during this time of upheaval in our healthcare system. Some surgeries had to be delayed, and that was unfortunate. Resources had to be deployed in other areas, and that was really hard on patients. And it was also hard on the doctors to make those decisions and to have those difficult discussions with our patients. We know right after the pandemic that there was a 60% drop in cancer surgeries the months right after the pandemic was announced. Certainly that's improving, but we know we have a long backlog. And we also know that there's equity issues and access issues that existed before, but maybe have been amplified during this time period, that we need to work together to make sure that our most vulnerable are getting the cancer care they needed. There's a lot of questions that remain in terms of cancer patients and the need for potential booster vaccines. We don't know the answer to those yet. As the data comes, we want to be able to adapt and to provide the best cancer care in the world to our patients. Cancer patients were very vulnerable at the beginning of this, and we were able to get them vaccines very quickly and on an accelerated pathway. I think one of the things that Dr. Viela was talking about, I've seen particularly in my cancer patients, has been a degree of isolation, a fear, anxiety that's emerged during this time. As I mentioned, struggling through cancer during the global pandemic has been a real challenge for many patients. I had one patient who was on chemotherapy and one day broke down in the clinic room to tell me that she hadn't seen her family or her grandchildren in over 9 months and was basically isolating herself alone and going through chemotherapy in complete isolation. And the worst part of it is I couldn't even give her a hug, given the situation that we were in. But I fear that there's many of these stories. So where are we headed? Well, like in the other areas, virtual care became a reality. We had to keep social distancing. So we had to use virtual care. I would say many times it was not by choice, by necessity. And that would be, as Dr. Sinha said, primarily on the phone, but also on face-to-face video conferencing. It worked really well for some. It didn't work so well for others. And I think what we need to do now is find that right balance. There's advantages to virtual care about bringing our caregivers, friends, and families in. But for some people, it's not the right option. And certainly we need to be able to find that right balance and work to be able to provide the care that we're able to in an effective way, virtual or in person. A lot of our patients have been scared to go to the ER and get help. They may have been sick, they may have had symptoms from their cancer, and they were certainly scared. And I think obviously we want to send the message now that we're here, we're ready. Please come in if you have symptoms. Please come in if you have health concerns. We're ready to take care of you. We also know that there certainly was a lot of missed cancer during that time. We estimate that there was about 1 million fewer colorectal, breast, and cervical screenings that were missed during this time. Mammograms were down in the first few months by 97%, Pap scans, Pap tests, colorectal screening. So I think we recognize there's probably a lot of undiagnosed cancer out there. What we're already starting to see and what we expect to see is a lot of advanced stage cancer, where the treatment's going to be complex, where it's going to be a bit harder to treat. And I think our system needs to be ready for this. So the collateral effects on the cancer system, I expect to be significant. Added to this, we have a workforce. We have a great cancer system in Ontario, but certainly our nurses, our doctors, the whole team, everybody is tired. It's been a very challenging 16 months. There's a high degree of burnout. So, what can we do? I think the first thing we need to do is encourage patients to come back. We're here, we're ready for you. Don't be afraid to seek medical care, whether that be in person and virtual. And I think we all have a lot of work to do to find new ways, new models of care, find resources so that we can catch up on this backlog and continue to provide, great cancer care in Ontario.
Yeah, thanks, Dr. Singh. And, I'll tell you, it was a very sort of moving story about one of your patients, and on a personal level, that's a similar story that my grandmother went through 6 or 7 months ago. And so, I think that this touches so many different people. And as you're describing, cancer, it doesn't stop. And so it doesn't stop for the pandemic. And how do we really, moving forward, create an environment where we can pick up the pieces and hopefully continue to deliver the best quality care for our patients, for sure. And on the point about virtual care and allowing it to be again used in an appropriate way, there's a dose that we need to figure out. There's a frequency, there's a duration, and there's we have to very much select the right patient for that kind of modality. So I think that these are conversations that of course are happening in earnest, but require further drilling down on in order to really understand at a high level what the most appropriate way forward is. So with that, first of all, I'd like to thank Dr. Singh, Vilela, and Sinha for being here and for sharing your expertise. And what we're now going to do is we're going to open up our Q&A session. So to members of the media, please put your questions in the Q&A chat. If we don't get to your questions in time, the media team at the OMA will follow up with you. And you can also email media@oma.org with additional requests for interviews. We will also have a recording of this session available later this afternoon. And so with that, I'll turn it over to Ryan, who will help to moderate the next phase of our discussion.
Thank you, Dr. Kassam. The first question I'll direct to Dr. Sinha. Are there other provinces or countries that have a good model of home and community care for seniors? And is there one that you'd recommend as a model for us?
Yes, so the country that I think most people know that I'm quite enamored with is that of Denmark, for example. I don't think any country around the world has got it right and got it perfect. And certainly lots of countries are exploring. I'll be in Iceland actually in less than a month, because we're actually developing an entire new aging strategy for Iceland that the Minister of Health is launching, that really focuses on reimagining long-term care, home and community care to a much more integrated model with what seniors actually need. But in Denmark, you have a country there, for example, versus Canada, that spends twice the amount that we do on our of their GDP on long-term care. That's home and community care to nursing home care. So that's 2.4% of their GDP versus the Canadian average of 1.3%. We actually spend 30% less as a country than the OECD average on the provision of long-term care And compared to the OECD average, where they spend about a third of their dollars on providing home and community care versus 2/3 on nursing home care, we spend about 87 cents on the dollar as a country on having people go to nursing homes versus receiving care in their own homes. In Ontario, under the previous government, we were able to actually significantly start shifting that budget so that we actually were putting more money into home and community care, which allowed 30,000 more older Ontarians to be able to live in their own homes who were long-term care eligible. So we were starting to approach a Denmark effect, but we stalled on that path. And so now we have 38,000 people who are on our long-term care wait list, but we have probably triple that amount of individuals who don't have enough adequate home and community care that they can get through with the support of their doctors. And so the challenge with that is if you can't get enough care in the community, where do you end up? In a nursing home? And in order for Ontario to build 30,000 new beds, which is promised over the next 10 years, and to redevelop 30,000 beds that currently are built to 1972 design standards. That will be, according to our NIA report from November of last year, that'll be between $12 to $16 billion alone in infrastructure costs, let alone the care costs of caring for all these people in their own, caring for people in long-term care homes versus actually trying to care for them better in their homes where they want to be, and we can do it more effectively. So there are countries like Denmark that we can look to that have done a significantly better job of actually providing better integrated care with a community care focus, which is really what Ontarians are asking for now more than ever.
Thank you, Dr. Sinha. So the next question I will direct to Dr. Villela. A lot of people are anxious about going back to work, resuming former patterns of socializing, commuting, etc. What advice do you have for them?
So as I shared earlier, it's really about keeping up with the public health guidance as a means of understanding how to navigate the next steps. And really, it's going to be a time of experimentation. And everybody's going to have a different level of comfort for dipping their toes into the water. So I've heard stories, for example, people saying that even fully vaccinated, it's been so long since they've had a chance to connect with their family members, for example. So when getting a hug from someone, there's this sense of it actually being unusual, and even this moment of freezing up and not knowing what to do, things that were so normal for us previously now feel like they're on the other side of the spectrum. So each person is going to have to decide for themselves where they feel that they're ready, and just keep staying tuned to the expert advice around how to keep safe at these various different points in the pandemic.
Thank you, Dr. Villela. There's a follow-up. What kinds of mental health issues will we see after the pandemic?
So the mental health issues, as I had talked about previously, are going to be similar, just more so. We can think of the pandemic as a form of trauma, if you will, really at a global scale. This is something that we haven't seen a version of in about a century. So this is the first time that many people are going through this, and it really is a shared experience, and one which has created such upheaval. So from that, we can see a variety of different pieces coming into play. So for example, the anxiety disorders, the mood disorders, as I alluded to previously, how people might be managing that in different ways. And for some, it's going to come out of substance use disorders, et cetera. So it's really the full range that we're going to be seeing, and primarily on a more severe scale, as well as people are trying to process this traumatic experience that in many ways feels like it's never ending. And that's the additional part of it. There's still so much uncertainty, and that's what makes it hard for people to feel like they have a sense of control over what's happening next.
Thank you, Dr. Villela. The next question's for Dr. Singh. You mentioned that there's a cancer backlog. How are we going to catch up on cancer care?
So I think, there's numerous strategies being developed right now, and I think it's going to require real collaboration between healthcare providers, between physicians, between the healthcare system, and as well as between patients. So we're looking at how we can add capacity, how we can increase the resources so that we can deal with the backlog, unique ways of treating our cancer patients that maybe we hadn't thought about before. These may be opportunities that we could take forward. In addition, I think we also want to send a very clear message to our patients to come back, get screening done, get symptoms looked at, get assessed. We're all here for you. We're waiting for you. And so that we can deal with these cancers early rather than let them become late stage cancers where the treatment becomes a lot more complex. Certainly, it's going to take some time to clear the backlog, and we're going to have to have some out of our box thinking. But I think, we are committed to make sure that everybody gets the cancer care that they need, and that we can make sure that it's done in a way that is person-centered and respects the needs of our patients in Ontario.
Thank you, Dr. Singh. There's a follow-up question. How will doctors support patients as they wait longer for procedures?
So this is a really good question. I think we're being very vigilant and making sure that we follow patients along as patients have been waiting or cancer surgeries that have been delayed. As I mentioned, I'm not a surgeon, but my colleagues who are, this was a very difficult time for them to have to be able to try to decide how to use the limited resources that they had, the limited operating times they had, and having difficult conversations. They're anxious to operate again. They're anxious to get the procedures done again. And so we're following with our patients closely to make sure that there's been no detrimental effects, that we can get those people who need care urgently quickly, and then we can get the diagnosis done quickly as well.
Thank you, Dr. Singh. The next question is from Nicole Thompson, and I'll ask Dr. Kassam to weigh in. How is the OMA approaching the issue of vaccine passports, either for travel or for recreational activities?
So the issue of vaccine passports is actually the jurisdiction of federal and provincial governments, and that leadership is very much involved with determining a path forward. And I know that conversation is an ongoing one, and it also depends on other geopolitical considerations that are happening around the world. What the OMA has been clear on and continues to advocate for is as many people as possible to get fully vaccinated. I mean, our members have been on the ground, boots on the ground, trying to get as many people to have doses in arms as we can. We know that the vaccines work. We know that they're effective. We've seen the case numbers come down. We've seen our hospital ICU capacities improve. And what we know moving forward over the course of the next several months is to get as many people fully vaccinated as possible. We want to get those 2 doses in arms for all segments of our population that are eligible to be vaccinated. And this will allow for us to move forward in terms of our recovery, not only on the healthcare sector, but broadly speaking in society and in the economy. And so while we continue to advise all of our health system partners, that question specifically is better answered by the federal and provincial partners.
Thank you, Dr. Kassam. The next question I'll ask Dr. Villela to answer. We haven't heard much about increases in domestic abuse during the pandemic. Why do you think that is? And can you tell us more about what we are seeing?
I'm so glad that this question has come up because it's such an important topic and one that is not talked about enough. And really this comes down to the issue being around a culture of shame, silence, and fear, which makes it really difficult in terms of trying to really be able to connect people with the resources that could be of benefit to them. Unfortunately, with the pandemic, so for example, people who were maybe looking to take steps to leave an abusive home environment, they were being told to stay home because they were being told that it was safe. Whereas, safety obviously has many different layers. So that was a challenge. There's also been the issue around where people could previously have some respite. So their social networks or other resources that they were trying to use in order to escape these situations. A lot of these kinds of pieces were cut off. So it's been a journey, as we spoke previously about this idea of integration, back to where things had the types of resource levels as before. This has been a real part of where the next steps lie for this group, because it's in some ways been like an imprisonment. And that's why we need to continue to highlight what is out there, what is available, so people feel like there is a lifeline and that they are not stuck having to be in the situations that they are before. And the more we have these conversations, the greater awareness we raise, the more that people then can be checking in and seeing, wait a minute, something's not right. Is there a way that maybe from something I've noticed, I can help? Because it's not about, oh, I've seen something, but I don't want to rock the boat. It could be, hey, this doesn't look like it's okay. And is there something that maybe I can do?
Thank you, Dr. Villela. The next question is from Nicole Ireland, and it's directed to Dr. Kassam. We're hearing about devastating nursing shortages in other provinces, including Quebec and New Brunswick, partly because nurses are exhausted from working during the pandemic. Is this happening in Ontario, and is the OMA concerned about how this will affect the quality of acute healthcare?
Yeah, thank you for the question. And I imagine that there are similar circumstances across the country and frankly around the world where we're seeing burnout play out really across the health sector, whether it's with nursing staff, whether it's with physicians, whether it's with other allied health professionals. And of course, speaking on behalf of the OMA, and we represent physicians across the province, we know, and Dr. Singh actually is part of our burnout task force within the OMA. We have seen a rise in burnout. I can tell you as a physician who's been on the front line myself and have been working flat out for the past 16 months, side by side with my colleagues and peers, people are tired, people are burnt out. And the fact that we now have an increasing challenge with working through backlogs of care that will require health human resources and expertise, we know that this is a problem that needs to have systemic levers pulled in terms of policy and frameworks in order to find solutions. We are concerned about having our health professionals not have the capacity or the bandwidth to do their job in an effective way. So I have maintained, and the OMA has maintained, you cannot have healthy communities without a healthy physician workforce. And we need to continue to collaborate and come together to find those solutions, but certainly it is an increasing concern within the profession.
Thank you, Dr. Kassam. This next question I'll ask Dr. Sinha to answer. Sorry, it just left, it disappeared. Just as Dr. Singh said, we can expect to see more cancer diagnoses. Will we see more dementia diagnosis as the pandemic ends? And has the pandemic worsened symptoms for people who have already had dementia?
No, it's an excellent question. And I think as my colleagues have mentioned, there's been a lot of care that's actually gone, just a lot of diagnoses that have not occurred. And so traditionally when the majority of older people are interacting on a regular basis with their primary care providers, for example, or with other specialists, for example, it's those face-to-face, those human interactions that can sometimes help us as clinicians better pick up a diagnosis of dementia, identify issues. The challenge with virtual care that can be, especially if it's just limited to the phone, you sometimes miss those opportunities to actually provide that diagnosis and support. So certainly, I don't think necessarily that we're going to see that this pandemic is generating more dementia, for example. But I think certainly there have been a lot of misdiagnoses, for example, that will be more likely identified, which will then certainly create kind of a backlog of work that needs to be done. I think similarly, what we do know is that especially in our long-term care homes, in our retirement homes, and for older adults living in the community who haven't had access to the usual levels of care and support, or if you're a community dwelling older adult who's living with dementia and you used to be able to access adult day programs, for example, or other services in the community that have been significantly curtailed, we know that in all these settings, we've seen significant worsening of mental health but also dementia symptoms and dementia related issues. And so a lot more deterioration, a lot more issues leading to hospitalizations and people's inability to live at home. So dementia has certainly worsened for a lot of people living in the community. It's been harder to provide those individuals the right care in the right place at the right time. And certainly there's been a lot of misdiagnoses that we will be having to deal with in the coming months as well.
Thank you, Dr. Sinha. The next question I will direct to Dr. Kassam, but Dr. Sinha, you may also want to reach out, or sorry, answer. Why do we have so few geriatricians and how do we get more?
Oh, I'll absolutely let Dr. Sinha answer that question. He's a geriatrician himself. And just to preface by saying, we have doctor shortages in this province and in this country. We are a nation that has among the lowest per capita physician rates amongst our OECD peer nations. And, you know, when we think about 1 million patients and Ontarians not having access, for example, to a family doctor, we see that need continue to be ever present, and with a growing and an aging population, that's going to continue to be an issue. But Dr. Sinha, please.
No, thank you very much, Dr. Kassam. The reason why we have such an acute shortage, if you look at what Dr. Kassam was saying about just our physician shortage compared to other industrial countries, for example, we also have the lowest per capita rate of geriatricians, actually, of most major international countries. So first of all, I mean, the average life expectancy of an Ontarian back in 1900 was 51 years of age. When we created Medicare, just about over 50 years ago, the average Canadian was only living into their late 60s. So geriatrics as a specialty was only recognized in Canada in 1982. We've always had children and we've therefore had pediatricians. So A, we've been slow to develop a specialty, and then B, in terms of staffing up, for example, again, there are various government policies that haven't really been in place that we need in terms of understanding what's our health human resources strategy for physician staffing in Ontario versus Canada as a whole. So when you look at other countries, again, I point to my favorite country of Denmark, if you will, after Canada, of course, what you'll see is they actually have a national human resources strategy. When I was there 2 years ago, for example, they've laid it all out, showing that they plan to increase the number of geriatricians by 70% in the next 10 years alone, for example, and they already have a pretty healthy number because, again, they're looking at their demographics, they're looking at the needs and other needs that obviously their populations are facing. We don't have any such strategy right now, and so we're perpetuating these without clear active policies saying what exactly are the needs of Ontarians, how do we project them to evolve over the coming 5-10 years, for example, and then how do we allocate our training positions accordingly and our recruitment strategies accordingly to recruit the types of physicians, nurses, and other healthcare professionals that we need. Without such a strategy, we're really not setting ourselves up for success and really making sure that not only are there more geriatricians, but our entire healthcare workforce is enabled to better care for older adults. And that starts by making sure that we have no medical school in Ontario that actually teaches geriatrics as a mandatory course the way they all do pediatrics. So there's a lot of different things that we aren't doing that other countries have definitely made much more progress on. So there's a lot of work that needs to be done. Yet after 10 years of working with government here, we made some progress, but there's a lot more that could be done, and we know what to do. We just need to do it.
Thank you, Dr. Sinha. The next question I'll actually ask all panelists to answer. Maybe start with Dr. Kassam. So we have in Canada or in Ontario, a high amount of vaccinated population. How do we get those remaining to be vaccinated?
Yeah, so we're touching on a very important point, which is we need as many people, ideally 100% of the population, fully vaccinated who are eligible. And we're not quite there yet. We have done a fair amount thus far. The vaccine campaigns, I think, at least in Ontario, have been robust. We're doing anywhere from 150 to 250,000 doses a day. I think that's a really strong metric for where we are. But what got us here might not get us to where we need to go. And so what we really need to focus now on is capturing that 10 or 15 or 20% of the population that might be on the fence, might have some hesitancy, might be a little concerned about the vaccines themselves. And really this comes down to education. It comes down to access for people who perhaps don't have access to the places where they can get the vaccines, which is where these targeted approaches in the GTA and other places are being rolled out, and we're seeing a lot of success with that. But really this comes down to making sure that we capture that 10 or 15 or 20% that's still out there and do so aggressively over the course of the next coming weeks.
Thank you, Dr. Kassam, and I invite other panelists to answer if they would like to.
I'm happy to, oh, go ahead.
Go ahead, Dr. Singh.
No, I was going to say, I totally agree with Dr. Kassam. You know, when we recognize in our cancer population that these are some of the most vulnerable patients and we really wanted to get the vaccines out, we really started an active campaign to open dialogues. We did weekly webinars for our cancer patients. We had discussion groups, we had focus groups, we had developed patient-friendly material. I think the key to getting beyond that point, exactly as Dr. Kassam talked, is conversations. It's about education. It's about listening. It's about hearing about the concerns, helping to educate people, address them, have a back and forth conversation, and then access. Make sure that we're dealing with this from an equitable point of view. And those people who aren't able to get the vaccines or have other challenges, we have to work with them to be able to go forward with that. And that's especially true in our vulnerable populations. And we've certainly taken that approach in cancer, and we may need to do that again if booster doses are needed in vulnerable populations.
And one of the, and just the one thing I want to add is that right now, when we think about the older population in particular, again, when 95% of our deaths have been represented by older adults, for example, I think at the beginning, people were really worried about hesitancy and always talking about, oh, it's hesitancy is going to be our worst nightmare, for example. But if you actually looked at all the polling from last year, even before we even had a vaccine available, we were seeing numbers as high as 91% of older adults, older Ontarians saying, hey, as soon as there's something there, get it to me because we're in the line of fire. The challenge is right now when, so our National Institute on Aging has a older Canadian COVID-19 vaccination tracker. And what we do know is right now, when you look at percentages of people with one dose who are 60 and above right now, Ontario is one of the 3 poorest performing provinces right now. So again, we'll say at least 89.9% of older Ontarians 60 and above, and 91% 80 and above have at least had their first first dose of the vaccine. Ontario is one of the 3 worst performing provinces in the country on both the 60 plus and the 80 plus, which really talks about the diversity of our population and the need to really make sure that we are, to get to that last point, we're getting to those people where we need to them, because there are other provinces and jurisdictions. If you want to take Nunavut, for example, and the Northwest Territories, for example, Northwest Territories have vaccinated 100% of their folks 80 and above. Newfoundland and Labrador, 99. Manitoba, 99%. Above what we have accomplished in Ontario for our 80 plus population. So if we just want to say, oh, it's our geography, can't really stand behind that. There's a lot more work that needs to be done, and partly it's we need to better enable our primary care providers, our pharmacists. You know, we need to make sure that we're getting out there, because again, these are those relationships that matter. And when we have so many Ontarians that don't even have a primary care provider, or who might be homebound, or might be racialized, or there are other reasons why there could be increased issues of access, these are the things that matter most, especially to older people as well.
Just jump in and add a little bit as well to some of what our colleagues have just shared. So with the age of social media that we're in, there have been clearly a lot of benefits. At the same time, there's been an explosion of content, which has led to, for example, misinformation, mixed messages, and subsequently mistrust. So people have expressed anxiety around what to believe. So for example, women have talked about their fears that if they take a COVID-19 vaccine, that this could lead to infertility. So that's why it's so important to have the strong public health guidance that's easy to understand and is going to be addressing the core concerns.
Thank you, panelists. So, Dr. Sinha, in the context of today's announcement that they're removing the requirement for fully immunized and asymptomatic staff and visitors, that they no longer need to be tested before entering long-term care homes, is there anything that we need to do to prevent ongoing outbreaks in long-term care homes?
We just need to get everybody in these settings vaccinated. So, there was a silly requirement, frankly. So I sit on the the government of Ontario's COVID-19 testing strategy panel, and in partnership with the science advisory table, we put out, our evidence in the science showing that doing asymptomatic testing for staff, for example, was overly burdensome and not being high yield. And really what we were talking about was the importance of just getting people vaccinated. So we've been actually saying that one way to incentivize our staff in our long-term care homes, which again, 90% have now received at least their first dose of the COVID vaccine, was to create better incentives by saying, if you've been fully vaccinated, you don't actually have to be subjected to asymptomatic testing, for example, because these are things that can help reward and provide more support for our staff. But the challenges that we've really had, to ongoing outbreaks in our long-term care system, is when we certainly have some homes that have lower staff vaccination rates and others that have excellent staff vaccination rates. And so Ontario has, gone one step by saying that they want to make sure there's a mandatory vaccination policy in our homes, making sure that staff either provide medical proof as to why they cannot get vaccinated or undergo an educational session. But now we've seen countries like England, Greece, France that are now just mandating staff in these settings to get vaccinated. And again, I think these are things that we need to think about. How do we protect the most vulnerable in our society? But right now, we want to make sure that we give every staff member the opportunity to get vaccinated, every resident the opportunity. And right now, when we have inadequate supports for most of the staff in long-term care homes to actually have access to paid sick days, for example, support for transportation, ease of access to vaccination, these are still lingering issues that we haven't properly dealt with in every location, that is actually creating unnecessary barriers to getting staff vaccinated. And frankly, we need to make sure we address that first before we look at doing things like mandating vaccination when really we haven't made it easy for people to do the right thing. So that's going to be our way to actually see a lowering of the number of outbreaks. But certainly right now, as of yesterday in Ontario, we only had 5 outbreaks across our long-term care and retirement homes in Ontario. And that's against 400 that we had actively in place as of January. So if anybody needs proof that vaccines work, look over to our long-term care and retirement home system and understand that when we have people who are unvaccinated, whether it be staff or residents, that puts them at greatest risk in general.
Thank you, Dr. Sinha. So this is the last question, unless our media colleagues have more questions. And this is a question for all panelists, and I'll start with Dr. Villela. What is the single most important thing that needs to be fixed to improve care for your patients post-pandemic?
I feel that similarly to what I was addressing previously with regards to consistency, for psychiatry, having a greater means of reaching our patients has been huge. And that particularly with regards to those who are experiencing addictions challenges. This is a population, for example, that can be very unpredictable in terms of their ability to connect with resources for a variety of reasons. And so being able to reach out to them through the telephone or through the video conferencing platforms has really expanded the reach and the ability to make progress in treatment. And part of that is because when people are at their lowest point, it can be hard to make the physical journey to see their physician. So by just being a phone call away or through these video conferencing platforms, it takes away the geographic barriers, for example, or even the challenges with motivating to even make a commute to see someone. And it's also given us insight into their their lives outside of the office setting. So sometimes you get a peek into someone's home, for example, and you're really able to see more of the reality in which they live, as opposed to having to visualize it in your mind's eye based on a description. So that's just one of the many populations for which telemedicine has been so important within psychiatry, and obviously there are examples in other areas as well. Just wanted to expand a little bit more on those who are experiencing substance use issues, since we didn't have a chance to talk more about that previously. So for psychiatry, it's really going to be core to continue to have access to these kinds of services for people, that this is not just going to be a one and done experience, that there is a recognition of this being incredibly valuable. And of course, in-person experiences absolutely do still have their time and place. This is a bit of a big tent approach, recognizing that having multiple options on the menu really just means that our patients are better served. And as discussed previously, when there is the issue of hallway healthcare, it's hard to say, well, we can't get patients access to more resources when those are being taken away. Thanks.
Thank you, Dr. Villella. Dr. Singh, what is the single most important thing that needs to be done to be fixed to improve care for your patients post-pandemic?
Well, I'm going to cheat and say two things. The first would be, I think our patients, ensuring confidence in our patients to come back, to participate in screening programs, to come back, to start talking to their family doctors about symptoms that may be happening. We really need to get back on diagnosing the cancers. We really need to get back to ensuring we can catch these cancers early when they're easier to treat and our cure rates are higher and more successful. So I think the message needs to go out to our patients that we're here, we're ready for you, and we want you to come back and get the care that you need. The second point I think is somewhat undermentioned and I think warrants a special call out, which is we really need to concentrate about the health and well-being of our healthcare providers. This has been a really difficult, challenging period for every healthcare provider in the province. Speaking on behalf of physicians, I know physicians are burnt out. We've seen record high numbers of burnout. We're seeing record high numbers of moral distress, and that is really challenging. And we cannot provide good care to our patients if our workforce is not healthy and is not strong. And so I think this issue is a really big one. Coming out of the pandemic, we have a lot of work to do in catch up, in redesign, in fixing problems that the pandemic's exposed. And we really need to place a lot of emphasis on making sure that we take care of our healthcare providers, our physicians, nurses, allied health, everybody, so that we can do the work that's needed to provide the healthcare that's required.
Thank you, Dr. Singh. Dr. Sinha?
Yeah, so I just want to say thank you to Dr. Singh as well, just for raising that issue of physician wellness, because it's something that really touches all of us. We've all had a difficult year and a half, and it's been incredible to see what our colleagues have done on behalf of our patients and each other. But I can't emphasize that enough. But the one thing that I would say is, in terms of if we're going to fix long-term care, the fact that we are all aging as Ontarians, as citizens, 1 in 4 of us will be 60 and older. We need to fix our long-term care system. And I don't just mean what we talk about nursing home care. It's about rebalancing and actually doing a full spread, long-term care support, focusing really on aggressively investing and building our home care system better. Right now, our current government has been decelerating its investments in home care. It's been accelerating a $12 to $16 billion investment. They won't tell you those numbers, but that's exactly what it's costed to build, 30,000 new beds and 30,000 rebuilt beds. But again, and then on top of that, to provide adequate amounts of care in a care home, it's about $1.9 billion, because we're only funding care homes to provide 2 hours and 45 minutes when the government has agreed that by 2025, they will raise the standard of care to 4 hours a day. Instead, we know that providing high intensity home care for people who are long-term care eligible costs about half of what it costs to care for someone in a home after the infrastructure costs. We know that home care is a good solution. It's something that we've always underinvested and not really focused on. But in countries like Denmark, where 2/3 of their long-term care investments are in home care, they don't have an ALC issue. They laugh when they hear about what we actually have, because they don't hold people hostages in hospital, as they like to characterize what we do, because they say people can go back to their own home because we provide them adequate care there. People don't have to go to a nursing home where they don't want to be. They can be in their communities because we provide adequate home and community care. It's a cheaper option. It's the more preferential option, but we are not thinking of healthcare as a system. We're thinking of it too much in a siloed way. And so my core commitment for my patients is to get more home care services and start from there. But that's kind of where I'd ended up my comments with.
Thank you, Dr. Sinha. Dr. Kassam?
Yeah, thanks, Ryan, and thanks everyone. You know, on the point of burnout, just echoing what Dr. Singh and others have said, this was an issue before the pandemic, and the pandemic has only exacerbated this problem 10 or 20 fold. And so and I'm grateful for Dr. Singh and everyone else who is working really hard to support physicians and other healthcare providers in this time of need. And I can tell you that I know from our membership, it is an essential resource, and it will continue to be that way. You know, as a physiatrist, I see patients in rehab hospitals, and so they've come out of acute care and they need to try and get back up on their feet to try and get back home. And so those transitions between acute care and rehab and then rehab and home, I think that linkage, those transitions really need to be thought about in a more comprehensive way. And Dr. Sinha very much alluded to this as far as bolstering the need to provide care at home, but also being able to get patients who will need some tuning up to be able to do that. And so strengthening those partnerships, those relationships with those community networks, that I think is going to be essential moving forward. I see geriatric patients, I see younger patients with disabilities. And so those types of care pathways that really we need to start developing more comprehensively is something that I would like to see into the future, because I do think that we are headed to a point where that's going to be crucial in order to get people back home so that we can care for them. So with that, I wanted to thank everyone for attending today. Thanks to our panelists, first and foremost, for your expertise, for your continual work on the front lines, but also for your thoughtful feedback on a number of questions that I think were very, very salient to our and germane to our conversation. To members of the media, thank you for your thoughtful questions, and I hope that this session was helpful in informing your reporting. I personally look forward to watching and reading your coverage on today's session. And if there is a topic that you would like to discuss or to hear doctors discuss in the future, please send your suggestions along to media@oma.org. And thank you again for your time. Stay safe, stay healthy. I hope you have a great summer, and we'll talk to you soon. Thank you.